In this video I'm going to talk about the institution PPH protocols. PPH stands for postpartum hemorrhage. I'll be explaining about the main steps we should follow managing a case of PPH. Postpartum hemorrhage is a common exams question and it's pretty frequent. On exams you can find a long case or a problem. You are a doctor on duty. A midwife or a nurse came to you knocking the door 3 a.m. saying that a patient delivered a baby successfully and she bleeding so much.
Institution postpartum hemorrhage protocols.
And for me, I found it easy to divide these protocols into 2 sections. It's all about the primary assessment. Is she comatose? You measure the blood pressure, pulse rate, and whatever. So section 1 is patient's assessment. The level of consciousness, you measure the blood pressure, the pulse rate. Usually the blood pressure is low because of the blood loss, and pulse rate is high due to the compensatory change in the cardiac system, and the respiratory rate, it will be high, and the patient usually is in a state of air hunger. Number 2 is that step 2 and step 1 are really close to each other. They complete each other. They are so important, which is set an IV line, the cannula should be gray, size 16, 2 large bore cannulas, and you run whatever fluid nearby. Crystalloid, colloid, dextrose, no. So you avoid dextrose, assuming this is the blood vessel, and in shock there is like low amount of blood running inside the vessel. Dextrose play a role in the extra compartment, and this will lead to worsening the condition, and finally the patient will pass. So avoid dextrose. You either use a hemocene or plasma proteins. You transfuse blood and in the same time you prepare a 4 units of blood. After you do the cross matching and blood grouping, in case of pain you give morphine, $50 milligram IV. Otherwise you did all of these 3 steps successfully and the patient is still in shock. In this case you have to infuse her with dopamine, as it will enhance the cardiac output, plus or minus corticosteroid, which is dexamethasone. Um, 50 milligram over 30 minutes per kg. Quick revision.
So, section 1 composed of assessment and managing the shock. So, you quick assess the patient, you measure the blood pressure and vital sign, fluid replacement, blood replacement, morphine in case of pain, and dopamine if the previous steps has failed.
Whenever there is a patient in a state of shock, whenever there is a patient in a state of shock, why do you first set an IV line to such a patient? Leave a comment below, and yeah, identify the site of bleeding. There are many causes of postpartum hemorrhage, being uterine atony the most common cause, due to many causes such as overdistension, multiple gestation, multigravida, and others. Second most common cause is lacerations, and the third cause is uterine rupture. Other causes such as DIC, which is rare, and uterine inversion, also this is rare cause. So to be systemic, when you are trying to identify the site of bleeding, you have to start from above down below. So you start from the uterus to the cervix to the vagina and to the perineal membrane. So after the patient has been stabilized, she is not in shock, she is nourished. The first thing, you have to place your whole hand over the abdomen, just beneath the umbilicus, and you feel for the uterus. If it's doughy-like or it is elongated, this could be a uterine atony. But if you feel like a stone or hard globular object, this is a normally contracted uterus. So the first step is place
Hand over the abdomen, and you feel for the contraction of the uterus. If it's not contracted, you perform a fundal massage, and assuming this is the uterus, this is the fundus, the upper part. So here you perform a fundal massage, rubbing like motions. So the first step is being fundal massage plus oxytocin infusion. Oxytocin will help the myometrium to contract really fast. Oxytocin has to be 40 ml in a liter. Oxytocin plus ergometrine, or fundal massage plus centometrine, or fundal massage plus prostaglandin, or fundal massage plus syncytial Blackmore tube intrauterine inflation.
Quick revision.
First common cause, as I said, is uterine atonia or uterine atonia. So you place a hand over the abdomen and you feel the contracted uterus. If it's contracted, go and search on another spot. If it's not, you induce the fundal massage of oxytocin and ergometrine. Centometrine is a ready-made combination between oxytocin and ergometrine. Prostaglandin, and finally syncytial Blackmore tube. This tube is used in case of variceal bleeding or variceal, in case of variceal varicosities, and these varicosities are bleeding, so they inflate a syncytial Blackmore inside the esophagus. It's a balloon-like tube. And this is the esophagus, and the vessels which are dilated right here are being compressed, so no bleeding. The same idea goes to the uterine atonia. They inflate the balloon right here, like so. This is the balloon inflation with a normal saline, and the tube is outside.
Patient is still bleeding. The next step is to examine the cervix. So cervix and vagina, you have to quick examine them under adequate light. So cervical and vaginal examination under adequate light. If there is laceration or torn, you have to repair either surgically or using sutures. The cervix and vagina are normal and they're still bleeding. You have to think about the third most common cause, which is the uterine rupture. And retained placenta. The meaning of retained placenta is assuming this is the uterus and the baby has been expelled. Sometimes the expulsion of the placenta is incomplete, so you have to ask before you manage such a case if she delivered the placenta, if she delivered a complete placenta or no. So retained placenta is an accessory placenta found inside the uterus. This will cause bleeding. In step 3, if there is still bleeding, you have to do a quick laparotomy, as the cause could be retained placenta or uterine rupture. In case of uterine rupture, the management will be depending upon whether the patient is primigravida or multigravida. So a prima gravida, this is her first pregnancy ever. You have to save the reproductive life of hers. So you do a rupture repair or uterine repair. On the other hand, if the patient is multigravida, she gets like dozen of children, you counsel her, and the management will be straightforward, quick, super cervical total hysterectomy. Assuming that you did a laparotomy and you find that the uterus is complete, not ruptured, you have to check the uterine vessels or the ovarian vessels. If they are bleeding, you have to ligate them. So another management could be uterine or ovarian vessel or artery. So you did all of these steps and the patient is still bleeding. In this case, the most probable cause could be injury to the vessels of the pelvis. So
you have to call help. You have to call your colleagues to help you in such a case, and the management will be internal iliac artery ligation or embolization.
Impressive info.
Such a patient with a postpartum hemorrhage can bleed 1 liter per 1 minute. So a patient can die in 5 to 6 minutes. And you have to do all of these steps really quickly. You have to master your skills, and you have to train. You don't have to work lonely. You have to call your colleagues.
So it's all your decision. You either rescue the patient, you send her to the ward, or you send her to the heaven. Hope you benefit and good luck.